My name is Kush Desai. I'm an interventional radiologist and associate professor of radiology, surgery, and medicine at Northwestern University in Chicago, Illinois, in the United States. So the VIVID trial was the investigational device exemption trial, or IDE trial, for approval, um, demonstrating both safety and efficacy of the Duo stent, which was acquired by Philips shortly after completion of the study. This device is unique in that there's a specific device for the iliac segment where there is a higher gauge nitinol segment cranially that's designed to withstand compression at the typical compression site where the right common iliac vein the right common iliac artery compresses the left common iliac vein. And then a more flexible segment caudally that will accommodate the curve of the iliac vein in the pelvis. Additionally, there's an extension stent that's designed for placement across the inguinal ligament where flexibility while maintaining the aspect ratio of the vessel is very important. So in that sense, this is the first stent with a modular design specifically sort of geared to deal with the challenges of iliofemoral venous obstruction in the anatomy. The population in the VIVID trial was similar to other investigational device exemption trials in the deep venous obstruction space. It consisted of patients with both non-thrombotic and thrombotic disease. The thrombotic cohort was further separated out into acute DVT as well as chronic post-thrombotic obstruction. And then, of course, there was non-thrombotic obstruction. So in general, the device design or the trial design was quite similar to what had been done previously. There are some minute differences between the trials, but these are common trials that are really geared towards showing the safety and efficacy of the device. So the key findings were several. One, the device is safe and effective, was able to maintain patency in the vast majority of patients with non-thrombotic disease. And the expected number of patients has been shown in other trials with thrombotic, specifically post-thrombotic disease, which was the majority of the thrombotic cohort. It also demonstrated that there was a sustained improvement in quality of life following treatment of deep venous obstruction, which has been borne out in other studies as well. So certainly gratifying that there is an option. There are now several options for patients with deep venous obstruction. The implication of this trial is that it provides another option for treatment of patients with deep venous obstruction, both non-thrombotic and thrombotic obstruction, with a device that's specifically designed for the anatomy. I think we'll need to see further data to see whether those design differences bear out to any material differences in clinical outcomes. But for the time being, it's certainly gratifying to have a device, another device in our armamentarium to treat these patients. I could go on all day on all the different types of trials and studies we need in deep venous obstruction, but I'll kind of boil it down to just a few of them. The first is we need very long-term outcome data in patients that are treated with iliofemoral venous stents, and certainly there will be cable stents on the way as well, to show how these patients do over the very long term. And the reason for that is fewfold, but in my mind, chief amongst them is the fact that these patients are typically quite young, and device durability and patency maintenance is a matter of decades compared to the arterial counterpart. And so showing what happens and how we can improve those outcomes by parsing that data and certainly design the next generation of devices, whether it's on stent maintenance or on the stent itself. And I think it's going to be both, will be driven by very long-term outcomes data. So I think that's sorely needed. The other favorite of mine is tying more physiologic correlates into deep venous obstruction research. Right now, a lot of it is qualitative and is driven by instruments and ultrasound analysis. But for example, we have very little in the way of showing what velocity inflow we need to maintain a stent in a post-thrombotic obstruction. There's been certainly a lot of work on inflow classification. July and his colleagues have done very important work, and we eagerly await that classification system. But the next step in that, I think everyone that is active in this area would agree, is robust research on physiologic endpoints that we can tie to anatomic classification to clearly demonstrate which patients are going to have a durable outcome. And finally, I would say the frontier that we're actively pursuing is inflammation and its role in deep venous obstruction. and there's some research efforts underway, and we certainly all await the results of those trials.